Hi there, and welcome. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to thank you for joining us for yet another episode of our educational webinar series. Our focus today, managing fears and phobias in kids and teens. This is such an important topic because, let's face it, growing up can be frightening. And while it's not uncommon for a child to be scared of imaginary foes or a teen to be afraid of social rejection, those and similar fears can lead to significant mental health challenges when not addressed with care. So, just what are the signs that typical childhood and adolescent fears have become more serious? And when is the right time to seek professional help? Let's get some answers. Joining us now is Dr. Jacqueline Sperling, a clinical psychologist and co-founder and co-program director of McLean's Anxiety Mastery Program. She specializes in working with youth who present with anxiety disorders and or obsessive compulsive disorder. And we might add, she is the author of the young adult nonfiction book, Find Your Fierce: How to Put Social Anxiety in Its Place. Jackie, thanks so much for joining us today.
Thank you so much for having me.
Well, let's start with some important vernacular for our conversation. Can you give us some basic definitions for fear, anxiety, phobia, panic? Can you walk us through those?
Sure. Fear is a universal emotion. All humans have it, and it's there we need it to help us prepare when there's an imminent threat to our safety. Anxiety is also under that umbrella of fear, and it's more along the lines of thinking about something that's going to happen in the future. And we need both of them, right? Fear, if there's a fire, you want to get out of there. There's a tiger in the jungle that you've encountered, right? Early humans want to get out of there. And for anxiety, it also can be helpful too, right? If you have some anxiety thinking about the future, perhaps a student thinking about a test in the future, that may motivate them to study for a test. Key piece there is, though, to have the emotions in check and keep them in check so that they're not bossing you around, though, and that sometimes they can get to that level and to that degree. And something we'll talk a little bit more about that later today. And a phobia is also, that is a very specific fear about a situation or an object or environmental circumstance, like could be an animal, like a phobia of dogs, or it could be a needle or injection phobia. And it has to be experienced for at least 6 months and has to get in the way. So if someone's going to have a needle injection phobia, that would look like them not getting their needed blood work or vaccines and experiencing acute distress when exposed to that stimulus.
Great. And then the last of those, panic. What do we mean when we talk about panic?
Thank you. Okay. And then for panic, that is an intense acute episode that peaks between 10 to 30 minutes, and you have a rush of anxiety. You may think that it may be having a heart attack or losing control, not sure what's going on. And you'll have at least 4 physiological symptoms. So it could be a racing heart, shortness of breath. You may feel sweaty, clammy, dizzy, shaky. Some people feel like things aren't real or disconnect from their body. So it could be a whole handful of symptoms, but it's not something that's prolonged for hours. It's something that comes really intensely, and it peaks between 10 to 30 minutes.
Okay, we're going to talk much more in detail about fear and anxiety and phobias and panic. I want to start, though, by asking you about the mechanics of fear. We sometimes talk about the amygdala or fight, flight, or freeze, for example. What's happening physiologically when we are experiencing fear?
So there are a couple of systems part of the autonomic nervous system, and one is the sympathetic nervous system, and that's where that fight, flight, or freeze system is housed. And this is there to help us prepare for our body when there's a threat to our safety. We need it. It's an alarm bell. It's like a fire alarm, right? If there's a fire, you need the fire alarm to sound it to help everyone prepare to get out of there if there's a fire. So you have this alarm system in your brain, and it works when, let's say, as I say, the fire, you prepares your body to get out of there. Think about an early human that may have encountered, I've mentioned the tiger in the jungle. You're not going to sit and have tea with the tiger, right? And probably not going to be a success if you try to fight it or freeze. So you're probably going to get out of there. So what does your body do? It sends signals to your body. It's like, oh, there's a threat to our safety. We have to get out of there. So your body starts experiencing physiological symptoms to help you keep you safe and get out of there. So your pupils may dilate, they may get bigger, and that's to help you see better. You may start breathing more heavily because the heart's pumping blood to your hands and feet so you can run faster. You may start sweating to cool you down. can help you make you slippery for the tiger too. You may start feeling dizzy. No time, no need to think, right? The blood's rushing away from your head to your hands and feet so you can run away. Some people might find that they feel like they're going to throw up or they're going to have diarrhea. And you may be thinking, why in the world is that adaptive? Well, actually, it helps make you lighter so that you can run away faster. So all of these physiological symptoms are happening as a way to protect you and keep you safe. The thing is, sometimes the sympathetic nervous system sounds a false alarm, and the alarm still sounds the same. So I'm often talking with youth if they're in a school, and I'm like, if you just hear the fire alarm, I was like, how do you know if it's a real fire or a drill? And they're like, well, if it's a real fire, you smell smoke or you see smoke, right? Or you see people rushing out, right? With heightened anxiety. And if it's a drill, people are walking slowly and calmly, and the fire truck takes a while to get there, right? But if you just heard the sound, you wouldn't be able to tell. You need to collect data. And for some people who may experience heightened anxiety where it's a false alarm, they may not be collecting the data. They think there's a real threat to my safety right now, but it's actually that alarm system that's going off as a false alarm. So we need it to help protect us, keep us safe, and sometimes it can go off when there isn't a safety threat.
Yeah, I was just going to ask you to sort of accentuate that point for us because it's important. There is a certain utility to fear. I mean, fear is not necessarily always a bad thing. It can serve us.
Absolutely. And you want me to elaborate more on that just in terms of?
Yeah, why don't you?
Well, just right, we need it, right? As mentioned, like if there's a fire or there's a natural disaster to keep yourself safe. So it actually is there to serve us. That's why it's one of those universal emotions, no matter from which country you come, whatever language you speak, everyone has it. It's just a matter of making sure that it's not getting in the way of the things that you want and need to do when there isn't an actual threat to your safety. So sometimes when those false alarms are going off, we may then misinterpret some cues or think that there's a threat to our safety, and then it can stop us from doing the things that we want and need to do when there isn't actually a threat to our safety. But fear is actually good for us in certain doses, in certain settings.
And we'll talk much more about when it's not so good for us. Our focus today, Jackie, is kids and teens. So let's sort of zero in on them for a moment here in terms of common fears. What are some of the more common fears for kids, or let's call them children, and then maybe also for teens? Can you walk us through some of the more prevalent fears in those groups?
Well, some of you have ever had infants, and you may see this period of time where there's that stranger anxiety that starts between around 6 to 8 months and may peak to 12 to 15 months. That's a developmental stage where youth go through where they then are more attached to their caregivers, and it's hard for them to separate to go to another person that you may pass them off to do that. But that tends to dissipate over time. If it doesn't, then that would be another conversation where it's developing into something more of a separation anxiety. Some younger kids may have concerns about the dark. They may worry about like monsters in the closet if they hear about them or under their bed. So there may be some fears. They tend to be short-lived and to dissipate over time as they get older, as they start to get experience and realize, there are no monsters under their bed, or they start to sleep in the dark and realize nothing happens. And so once they get that practice, they tend to dissipate over time. For some, they do not, and they may develop into, phobias that do then get in the way. And we can talk more about that too. It sounds like you're going to bring that up.
Sure, absolutely. How about for teens? What are some of the more common fears for teens?
Teens are developmentally become more concerned about their peers, so their peers become more important to them. So they may be more concerned about, their image, their identity, what they say, what they do, because they're concerned about, what will their peers think are fitting in, again, in terms and establishing who they are in the world there. In terms of them being like a developmentally appropriate fear, they're not necessarily ones where they're going to have a specific like, I'm afraid of the dark or I'm afraid of monsters like that younger kids may have. That tends to happen more in younger children, but it is developmentally appropriate for an adolescent to care more about what their peers think about them.
Okay, so you sort of laid the groundwork for us. Fears can be healthy. Fears are common. How do we know when they become problematic? Is fear severity on a continuum, for example?
Sure. So as I mentioned, right, it's this universal emotion. We all have it. We all need it. When does it start to get in the way is the key signal there. Like if it starts to stop a child from going to school, doing their extracurriculars, completing their homework, seeing their friends, attending family gatherings, when you're noticing that it's getting in the way of anything that would be typical for a child's daily life, then that's signaling that it has crossed a threshold where it's no longer, oh, the everyday fear and anxiety that all humans have and need has gotten to the point where it's getting in the way and they're not able to do what they want and need.
Is that the juncture when you might reach out for professional help, or does that come later?
I'm in the mindset, therapy is not going to hurt you. It's not sort of like a surgical intervention, right? Where that's the point of no return there. And these are life tools for humans, right? That I think can be helpful for all humans. So if you are concerned, you are starting to see signs and you want to make sure that it doesn't develop into something further and give someone tools about how to practice gradually facing their fears or collecting evidence to see whether it's a real alarm or a false alarm, helping kids be a detective in that way. I encourage you to reach out, meet with the child's pediatrician can also be a resource there, and they can talk about whether or not it might make sense to make a referral or to connect with the resource in the community. Also, because given the unfortunate state of affairs where the need and the number of mental health providers is not equal. And so if you are seeing something that they may be concerned about, so just, getting on a wait list if that's possible, right? Because then if it does eventually cross that threshold, maybe then that would align with a time where something might become available for support too.
Let's keep extrapolating. So, untreated, some of these fears can become more problematic. Walk us through where that can go. Can these fears grow into anxiety disorders? Can folks wind up with OCD? What should we know about anxiety disorders and OCD? Give us what we should know about those basic disorders that can develop, if you would.
Sure. So there are a variety of different anxiety disorders. So there's separation anxiety disorder, and that's a fear of something bad happening to you or your caregivers or loved ones when you're apart. And the symptoms would have to last for at least a month. You may see kids have a lot of nightmares about harm coming to them or to their caregivers. You may notice that they complain of physiological symptoms when they're about to separate from you, like they have stomach aches or headaches right about separating. It's hard for them to go away from you, whether it's at school or to a friend's house, sleepovers, to another family member's house. That might be an issue there, or it might be hard for you to leave them. Or sometimes it's hard to be on a different floor in the house, be an issue. So that some of the symptoms where it would start to cross threshold would be separation anxiety disorder. There's also social anxiety disorder, and that's a fear of being judged or embarrassed. And the symptoms last for at least 6 months. And it can be more focused on a performance type, like giving speeches or performing in front of others, or it can be more diffuse. Some people worry about eating in front of others, using public restrooms in front of others, participating in class, ordering at restaurants, asking for directions, speaking on the phone, talking to family members, going to birthday parties, large gatherings, having groups of friends where it's like more than one-on-one, texting, PE class, extracurriculars, any way you can notice it can show up in a variety of different ways where they may fear being evaluated or judged or embarrassed. Were you going to say something, or did you want me to?
I was going to ask you about OCD, but I suspect that's where you were going next,
Well,
regardless.
there are multiple other anxiety disorders, and then I can also get to OCD, but did you want me to touch on OCD now?
No, let's keep those in. No, let's keep those in order. Then stay with the anxiety disorders, and then we'll move
Okay,
over to
sure.
OCD. Thank you.
So there's also panic disorders. We were talking about panic attacks. Now, you can have a acute panic attack, meaning, for example, a child may have acute panic attacks if they have social anxiety disorders, or any time where they might be in a situation where they worry about being judged or embarrassed. They may have those physiological symptoms in a panic attack that happens. That would be cued because there's a known stressor that's setting it off. Panic disorders, of where they have a panic attack, it comes out of the blue. They're not sure what causes it. They have those physiological symptoms and they start worrying about having a panic attack again, and then avoiding places or experiences where they think they might have another panic attack. And that can happen, that they're happening for at least a month and then reaching that level of interference. There's also agoraphobia, and there may be a misnomer in the community to think it's this fear of open spaces. It's not, it's a fear of being in a space where you might be trapped or embarrassed and you can't escape. This often does happen in public spaces like public transportation or crowded malls or concerts, places where they feel like I might not be able to get out of there. For kids, it can also be where they're in the back of a class and they worry that something may happen, they may be embarrassed and be trapped and won't be able to get out of the class because they're in the way back. Sometimes people may think it's separation anxiety because sometimes kids with agoraphobia may feel like it's a safety behavior if they're always with the caregiver, like, oh, if I go to this place, my caregiver can help me escape that place. But it's not actually separation anxiety. It's more that the caregiver is providing an exit to a place in terms of for them to help relieve their anxiety in those situations. There's also selective mutism, where a child may stop speaking to those, particularly outside of the home, for at least a month. And these are kids who are usually chatterboxes, like they have the capacity to speak, but they may stop speaking outside the home. And that can often be linked to social anxiety as well, and not 100% always at the same time, but that also can happen. There's also generalized anxiety disorder. Oh, sorry, I'll get to the OCD. Generalized anxiety disorder, or GAD. And if you worry about one thing, it's common for you to worry about multiple things. And so this is someone who has a range of fears. It could be about their health, their family, school, the state of the world, and they're thinking about these fears for most of the day, for most days of the week. It can come along with physiological symptoms, restlessness or fatigue, irritability. It can show up in terms of worries about perfectionism, things having to be just so, debilitating in terms of doing homework or spending time with friends. And that's happening for at least 6 months. And usually what families will say is that, like, my child has always had a tendency to worry, and doesn't necessarily come out of the blue, but there may be stressors that exacerbate those worries. We have talked about specific phobias. Those are also another form of anxiety disorders where you're worried about a specific thing, where it could be about needles, blood. Vomit is a very common one in youth. Animals, could be specific situations just in terms of like elevators and things like that. And then I can go on to OCD. Did you want to ask something about?
Let's do that. And in fact, Jackie, once you explained what sometimes can be confusing for folks is OCD is no longer considered an anxiety disorder per se. And that gets us a little bit into the weeds with the DSM and classifications and so forth. But I think it would be helpful for you to kind of break down for us why OCD is now seen as something distinct from those anxiety disorders that you just ran through.
So very much so related. The reason why it was separated is because it isn't found that it can affect different areas of the brain. And so that's why they're put it into an umbrella of its own. That being said, it's very common for kids who meet criteria for OCD to also have anxiety disorders. And the good news is that the treatment, the tools that they learn can apply to both of those. But OCD stands for obsessive compulsive disorder. The obsessions are these intrusive thoughts that come, they do not match how the child feels, they're distressing, and they may tell them to do certain rituals, whether they're inside their head or ones that you can actually see, and that the rituals may bring down the distress in the short term, but in the long run, they reinforce or strengthen the obsessions, and then they keep coming back. And for it to meet the level of crossing the threshold of OCD, the rituals and obsessions would have to take up at least an hour a day, or start interfering with their daily life. This distress is so interfering, even if it's not to an hour. And some people think that OCD is more focused on a concern about germs or contamination fears with hand washing. It can show up in a variety of different ways. There are different clusters of fear. So there's contamination. Sometimes it is with germs of getting sick. Sometimes people worry about being dirty or contaminated, but there's also doing things to feel like the just right. That's very common with kids. It's like, I'm not worried about something bad happening, but it's more like I have to do something until it feels just right. Open and shut a door until it feels just right. Tap my glass until it feels just right. Get in and out of a chair until it feels just right. There's rereading, rewriting, checking rituals. There are also something we call ego dystonic. So ego syntonic is a thought that is in sync with how you feel. Ego dystonic is a thought that is not in sync with how you feel. And there are some thoughts and some cases where kids will have some thoughts that are ego dystonic thoughts of wanting to hurt themselves or others, very distressing for them, and sometimes can get confused with the child for having actual suicidal ideation, but it's actually they don't want to hurt themselves. They're terrified of it, but the OCD makes them doubt whether or not they would do it. There are other symptoms too, and I'm just giving you some examples.
A lot to unpack in what you just shared about anxiety disorders and OCD. We're going to come back and talk a little bit about treatment for those challenges. I also want to mention that we're going to weave in some audience questions. That's a big part of what we do here. And I know folks have questions about very specific challenges with their children or whatnot, and we will get to those. I do want to drill down a little bit and circle back to phobias. You touched on these as well. How do we make a distinction between a phobia and more everyday fear and or anxiety? What sets a phobia apart from those?
Well, if we go to the example about shots, for example, I have yet to meet a child who's like, I love getting shots. I've yet to meet someone who feels that way, right? They may not be excited about shots. However, they still get their checkup, they still get their blood work, they still get the vaccines, even though they don't like the shots. It's to what degree is someone experiencing so much distress or that they're avoiding, they're not getting the shots that they need or the blood work. So it's that kind of avoidance or acute distress to the point where it's debilitating. That's where it's starting to that's where it's crossed the threshold and it's getting in the way.
And tell us a little bit more about some of the more common phobias, because I think these fascinate people as well. We often talk about common phobias for adults. Are there more common phobias for children and or teens?
So anxiety disorders are the most common mental illnesses, and then specific phobias are the most common anxiety disorders. So very common. I would say one of the most common ones I work with is also emetophobia, that fear of vomit, particularly in youth. And again, have you ever met someone who really, enjoys the act of vomiting when they're sick? No, and they may find that they have relief, but it's kind of like the shots. But it's like some people are so terrified of vomiting that they avoid eating. Sometimes they avoid going into long car rides. They avoid doing physical activities, avoid eating until they're full. So avoid watching movies or any clips where that might happen, or going to school because they're worried someone will be sick. So that's a very common one. Animals sometimes there may be like some kind of phobia of dogs, or depending on the environment in which one lives, like if there are maybe perhaps so much of insects or snakes, they may have a phobia of those.
What about the connection between phobias and panic attacks? Does one necessarily lead to the other? If you have a phobia, do you tend to have panic attacks around that or not necessarily?
So not necessarily. You can have a specific phobia without any panic attacks, or you can have cued panic attacks that I mentioned, right? So like anytime you see the shot or if you have a phobia of dogs, you may start having that rush of anxiety with at least 4 physiological symptoms that peaks between 10 to 30 minutes when you are exposed to that stimulus. If you have a fear of dogs and you see a golden retriever walking down the street, that may set off a panic attack for someone. That being said, it doesn't necessarily mean that like if you have a specific phobia that it's likely that you'll have panic disorder. That's not necessarily ones that are highly linked.
And what should we know about navigating a panic attack? I mean, that can be really frightening for a parent to watch a child go through one of those, for example.
Oh, absolutely. And terrifying, not just for the one who's experiencing, but also for the parent, feel really helpless. Like, what do I do? And in those moments, either you may be tempted to have them try to do like relaxation strategies, right? Like deep breaths. You don't want to have them do that, right? That actually can even exacerbate hyperventilation in that moment. And you want to actually have the brain learn it's a false alarm. They're okay, right? And that they can handle it. So what do? You actually want to have them practice mindfulness in this moment. So not try to resist or fight the panic attack, because then that will send a signal to the brain that it's dangerous and then the body can't handle it. So just to notice things non-judgmentally in the present moment and on purpose. So I have kids who will do like a body scan. So start describing how their head feels. It's like I notice tension from either side. I'm noticing beads of sweat going down each side of my face. I'm noticing that my mouth is extra dry. It's hard to swallow. I'm noticing that my heart is beating more quickly versus I'm going to have a heart attack. That's right, a worry or a judgment. It's like that's beating more quickly. I notice I have butterflies fluttering in my stomach. My arms are tense. My legs are shaking. So have them go all the way down. And then I'm just continue to cycle through until they ride that panic wave to shore. Because you can't experience an emotion forever. And emotions are like waves, right? Waves don't stay up forever. They do eventually go to shore. Some behaviors can make them crash prematurely, like a ritual or trying to resist or fight a panic attack, but then those waves come back even bigger if you do that. So you want to help them surf those waves to the shore.
That makes sense. What do we know about the driving factors behind phobias? Are there genetic components to this?
So it can usually to be a combination of things. I mean, someone can have a genetic predisposition to a specific phobia or an anxiety disorder. And then there can be environmental stressors that exacerbate it or set it off. So someone may have a vulnerability and then they may have a negative experience, let's say, with the dog, for example, and then that may set that off. With specific phobias in particular, there also can be a component of parental caregiver modeling. So if a caregiver demonstrates that a situation or an animal experience is threatening and they're afraid of it, then a child may learn that I should be afraid of that. And then that can then strengthen fears and set that off.
Let's talk treatment. This is obviously such an important part of the conversation because, as I understand it, anxiety disorders are indeed very treatable if you are working with a specialist and doing the right kind of care. So let's talk about what that right kind of care is. We hear a lot about cognitive behavior therapy. What should we know about that? CBT.
So really it's a, the gold standard of treatment for youth who are experiencing anxiety disorders, and also, a specialized type of CBT, the cognitive behavioral therapy, is exposure and response prevention, ERP, and that also applies for the anxiety disorders and OCD as well. Now, what does that mean? So CBT talks about the connections among your thoughts, feelings, and behaviors, and you learn tools how to address one of those components at a time, two of those components at a time, and all of them at a time, and then they can affect each other. So there are different tools that kids will learn. The exposure and response prevention component of that is a way to help kids gradually face their fears and learn that either what they're worried about was going to happen was not as bad as they expected it to be, or even if it was just as scary or it was even scarier than they had thought, they learned that they could handle it. Really key pieces. So you have them do it gradually and then they can gain some momentum and then realize, oh, wait a second, those were false alarms. I can do this.
You just touched on this in terms of having the kids address these fears almost kind of in a hierarchical way. Can you talk a little bit more about that? Working your way up a ladder, if you will, of those challenges?
Exactly. A bravery ladder can be an analogy that you use. I often like to think about like a swimming pool as well. So if you think about a swimming pool, Jeff, not on a really hot day, but maybe on a chilly day, maybe like 60 degrees Fahrenheit. And I were to say, Jeff, why don't you just go jump in the deep end? What would you say?
I want to start the shallow end.
You're like, no, thanks, right? And right, but I was like, okay, well, right, how about the shallow end? You already had me with it, and you're like, what would happen if you dip your big toe in? How would it feel at first?
It would feel cold at first, but I would acclimate to it.
Exactly, right? And then maybe you ease in, get a little bit further up to your ankles, up to your knees, up to your waist, and by the time you get to your neck, if I were to say, hey, Jeff, would you be willing to dunk your head? What might you say?
I could try that.
You might be open to it, right? You got your
Yeah.
whole body wet, and thank you for being willing to engage in that conversation. You got your whole body wet that way. You could have gotten your whole body wet by jumping in the deep end, but that probably would have felt like a shock to your system. So for exposure and response prevention, kids are gradually easing their way into the swimming pool and learning that they can do it. And if you think about a ladder, like if that were leaning against an office door and you start knocking off the bottom rungs of the ladder, if it's the things you fear the least to the things you fear the most, the height of the ladder gets shorter, right? If you could chop off the bottom rungs. And so what felt so far away and so scary no longer is as high up on the ladder because they've gotten some momentum.
Makes sense. What about finding a therapist? I mean, we have a lot of parents in our audience typically, and they're hearing this and thinking, okay, my son or my daughter might benefit from some of this treatment that she's talking about. How do I go about finding that therapist?
So a pediatrician can be sort of a first step there, asking a pediatrician who may be familiar with referral resources in your local community. Another option could be, particularly if it's an anxiety disorder, there's ADAA.org, so the Anxiety and Depression Association of America, and there are resources separated for the community and also clinicians, and then they have a list of providers who have noted that they are trained in this type of treatment, and you can specify the population, like age and what their presenting concern is, and find out if someone's in your area. Um, some people do use resources like Psychology Today. What I might suggest, if you are going to do that, just to make sure that someone really has a very focused specialty. Because, if you're thinking about a provider that says, they have like 12 different specialties, you would never go to a physician who says they're a radiologist, a cardiologist, an anesthesiologist, and also a surgeon, right? You want someone who really focuses on something. So just making sure that they really do focus on this treatment.
Can you touch briefly on level of care? And we sometimes hear about inpatient treatment versus outpatient treatment, for example. What should we know about that?
So there are different kinds of outpatient treatment. Outpatient treatment meaning that you sleep at home. You go to the treatment, or rather, or it's virtual, you log on to the treatment, or you go to the clinic and then you come home. Sometimes outpatient treatment, typical like first dose of therapy would be like weekly therapy, probably like a 50-minute session once a week. Sometimes providers may do it twice a week. There are intensive outpatient programs. At work, the McLean Anxiety Mastery Program is an intensive outpatient group-based program where kids attend the program 4 days a week for 2.5 to 3 hours each day for a minimum of 4 weeks. They're still doing outpatient treatment, but that can be a way to get some momentum, because 1 month of that type of treatment is like about a year of weekly outpatient care. So to get some momentum that way. There are also partial levels of care. So you're still sleeping at home, but you go to treatment pretty much during the school day, those hours. And then you get to the level where you're not sleeping at home. There's residential, and how that differs from inpatient is that the doors are technically not locked there, and there's a certain level of safety that the child can maintain while they're at residential. And then the next level would be inpatient, where the doors are technically locked there, and children usually experiencing some threats to their own safety, or their symptoms are so severe where they need that level of care.
You are generating lots of questions, and let me go ahead and work a few of those in here in no particular order. What are some common phrases that one can use when a child or adult is having a panic attack? I think this is getting at what might you say to somebody going through a panic attack? And you touched on this earlier, but perhaps you can give us a little bit more.
That's a great question. First line of communication is that I recommend that you validate, you acknowledge how the child is feeling without agreeing or disagreeing. Because in your mind, it'd be like, what do you mean? That's like the friendliest dog in the neighborhood. He won't hurt you, right? But in that moment, that child is terrified, right? So you want to make sure that you, even if you disagree, you acknowledge how they're feeling, right? You're feeling terrified right now. Like, this is really scary for you right now. And there is a piece, if you're going to say something afterward, this is going to go against all of your grammatical training, but I encourage you to use and instead of but, because if you insert but, you're going to negate and wipe out the validation you just said. So to hold the validation and then to show that two things can be true at the same time, use and in the middle. So
give us an example of that, if you would, Jackie.
Adding on this piece, so you're really terrified about this dog being here. You're really scared right now. And right now is important to ride out this emotion wave. So practice scanning your body and to ride that wave to shore. You can do this, right? And so like you're acknowledging how they're feeling in that moment, and you're helping them take that next step in that moment to ride that wave and to not resist or fight that panic attack or run away. There's much more to say about this tool about validation. That was very much so a cliff note, but wanted to think what you can say in that moment is very much so think, how do I first acknowledge how they're feeling? Because I may want to jump to problem solving, or I may want to let them know, like, no, this is like such a kind dog, or like, you'll be fine, like you've done this before. Like, you don't want to provide reassurance thinking it's not going to sink in, and it tends to reinforce the anxiety or avoidance. You want to acknowledge how they're feeling and hold the other side in terms of helping them ride that wave.
You just raised a great point that I want to make sure we get to. Reassurance. This is so counterintuitive so often for parents. Your child comes to you and is afraid of something and wants your reassurance that everything is going to be okay. It is the natural inclination of a parent to want to comfort that child. Talk, if you would, about when that can be counterproductive and what parents should do when they're faced with that awful situation where they really can't provide reassurance without helping exacerbate the problem.
It's so tricky because the protocol, the treatment goes against all human instincts, right? If someone asks you a question, your knee-jerk reaction is to answer it, right? Your child's in distress, your instinct is to help them, make them feel less distressed, right? And to protect them. The key thing is to think about, who am I supporting? Am I supporting my child, or am I supporting the anxiety, which is like a beast that will keep asking for more. So if you continue to provide reassurance that the anxiety is talking to you and not your child, it's like trying to fill a water bottle that has holes on the bottom. It's never going to fill up, right? Or like that play, The Little Shop of Horrors, like that plant just keeps getting bigger and bigger and it's never satisfied, right? And so I often will use a garden analogy. Think about like a rose takes just the right amount of sunlight, water, and nutrients to thrive in a garden. And those are the behaviors of which you want to see more. The dandelions, you so much as blink in their direction, they're everywhere. They don't take much. Those are the behaviors of which we want to see fewer. And that's where the reassurance seeking comes in, right? So like, is it the rose talking to you in that moment, or it's the dandelions? And so if you start to notice like, your child keeps asking questions over and over and over again, or is confessing things like I don't feel well, I think I'm going to be sick. Are they like, do I look sick to you? Do you think I'm going to be sick? Or was that cooked all the way? If they're worried about vomiting, or continuing to ask questions about when that doctor appointment about the vaccine is going to be, whatever the concern is, if you've already answered that question once and you start to hear it again, that's flagging to you that those are the dandelions, and you do not want to give attention to the dandelions. Now, what do you do in those moments, right? Because like this, I suggest it being a collaborative process. And so when your child is relatively calm, and ideally this comes from a therapy provider, we would do this too. But if this is something that you're taking on at home, there are 3 levels of a reassurance seeking bravery ladder or hierarchy, where you're gradually taking attention away from the dandelions. And then you would have your child pick which level with which they're willing to start. And then you would practice that response for about a week. And I'll say the levels in a moment. And then you would go to the next level the next week, and then the next level the next week, so that they know what's going to happen. They're not going to be excited about it, but they're not surprised. But if you just do this on your own without telling them, it's likely not going to work in your favor. So first level, let's say you have a child who is worried about vomiting, and they may say like, am I going to throw up? And you would say, that sounds like your anxiety talking. Is that your anxiety talking? Give them a chance to respond. Yes, no, maybe, whatever. It doesn't really matter. You then can respond like, no, you will not throw up. And like, yeah, that is providing reassurance, but in that moment, you're cueing the brain that it's the anxiety talking and not the child, the dandelions. That's the first level. The second level is you're removing words. So no words, no sounds. You're just using gestures. So if it's a yes or no question, right, nod or shake your head. If it's an announcement, like, I think I'm going to be sick, you do an okay gesture. Now, I appreciate there are communities that have tried to use that gesture in a malicious way. We mean it in the A-OK sense. And you're not saying like, I'm doing the okay gesture so I don't give attention to the dandelions, because that's more water to the dandelions. So no words, just the just the gestures. The next level is no eye contact, no words, no gestures, no facial expressions, active ignoring. Pick the lint off your shirt, count the ceiling tiles, Swiffer, pay your bills, do anything but give attention to the dandelions. And again, you want to practice something for about a week and collaboratively with the child. That's a cursory overview, but just wanted to give a
and as you stressed, that's a tough call for parents. I mean, and that's why you work with a professional and get some coaching along the way, I assume.
Absolutely. Right. Because if your child's in distress, right, you want to make them feel better, but recognize that those are the dandelions talking to you in that moment, and that they're false alarms going, and that they're worried about something as a threat to their safety when there isn't. And know that no matter how many times you respond, it's likely not going to make that question go away.
Something inherent in what you just shared is this notion of externalizing the fear, externalizing the OCD, if you want to work with that disorder, for example, almost looking at it as a bully outside of the individual. Can you talk a little bit more about that?
Yeah, so because a lot of times kids will fuse their identity with a mental illness, and we want to let them know that like, you may be experiencing this, you may have this, but it doesn't have you. You are not one and the same with an anxiety disorder, OCD, or another mental illness. It is something you're experiencing, right? So to separate it and to know it's this beast that can be really bossy and like a bully, and to help you take charge. But it's not you who's having those thoughts, not you who's doing those things. It's the anxiety or the OCD, it's the bully that's trying to make you do these things and take away the things that you really enjoy and wanted to. And so how do you boss back those worries so that you're more in charge and not the worries?
Let's talk about some considerations for educators. We often have teachers and other school faculty in our webinar audiences. What should they know about identifying some of these challenges in the kids that they work with, and what to do if they do have concerns about a child?
So sometimes I notice that like kids with anxiety disorders, even OCD, may be misinterpreted as having like oppositional defiant disorders. So educators would think like, oh, you're being resistant because you're not willing to go into this next class, or you're not to do this next assignment, whatever it is. And sometimes I find that it can help have help you have more compassion for the child when you learn from a family if they do have an anxiety disorder, to know that like that child in that moment feels like they're trapped in a cage with a tiger and the keys to get out are on the other side of that tiger. So that's usually what's happening. If they're in so much distress, usually we'll do whatever it takes to not feel that way. And so it may look like they're being oppositional, but really often they are rule followers, right? And that it's more that they're in that distress. So to keep that in mind, if you start to notice that a student is struggling, whether it's either to show up, right, or to engage in activity in the classroom, or they're not participating, or they're more withdrawn, right, that can be something where it's more like, notifying the family or setting up a time to speak with the family to share some things that you've been noticing. You want to not come in with recommendations, but just describe what you've been noticing and seeing, if that's consistent with what they've been seeing, and to talk about a plan. Because they could say like, oh, I mean, their chatterbox at home. I had no idea that they weren't doing this at school. Or they're like, oh yeah, I've seen that across the board. And we've been talking about this with our pediatrician. We're trying to get, into therapy right now. So to have that conversation with the caregivers.
Let me get to another of our audience questions, a very specific one. Are the approaches and strategies the same or different when anxiety comes with an autism diagnosis?
So in terms of when you're working with someone on the autism spectrum, some using want to be some of their symptoms you might have to do some concrete language in terms of for them to work on certain tasks. And it's very common for those who experience, autism spectrum disorder to also have an anxiety disorder and to do the exposure response prevention treatment, and they can respond quite well. But really meeting them at where they are and recognizing that there may be certain situations that are quite stimulating for them. And so it may be that they also need, adjunctive like occupational therapy that help with the sensory input. And gradually working on those fears as well. But you meet every child at where that child is and what are their individual needs, and recognizing like what is also co-occurring for them. But sometimes the language in terms of working with the spectrum may be using concrete language, because that may also be more of a fit for them.
We've talked about specific tips for parents and educators. We should also talk to our clinicians in the group today. At what point does a clinician, or should a clinician, consider referring out to either a child specialist or an anxiety disorder specialist? And what can they do in a more general practice? What would you want clinicians to know by and large about working with children and teens with anxiety disorders?
If you're someone who identifies that you don't implement, cognitive behavioral therapy with exposure and response prevention, for example, implement another treatment modality, there is value in what you have to offer, and it may be partnering with another clinician for adjunctive treatment when they're focusing on a different target and you're focusing on something else. And so if you're recognizing, you're like, what we're focusing on here is something different, and there are also these challenges with avoidance, then thinking about if there's someone with whom you collaborate in the community, you could also use the ada.org website to see if there's someone nearby with whom you can partner, and to talk with the family about referring to adjunctive therapy. It's very common for these kids to have, multiple providers. Sometimes they like to have someone where they're talking more about relationship issues and they want that space to talk or to play. And then there's also where they have adjunctive therapy where they're working on gradually facing their fears.
I would like to explore with you a little bit some proactive strategies that parents and teachers and other adults can use with children to kind of help them understand at a broader level what fears and anxieties are about. I mean, these are difficult concepts for kids to understand. Are there proactive strategies even before any particular issues arise that adults can use?
So early on, right, if you're doing reading at night with a child, there are ways to help kids learn about their emotions and how they show up in the body. This is not, I'm not, that doesn't have to be this publisher, but for example, Imagination Press is a part of the American Psychological Association has lists of books for different topics that you can look at for different ages. And ADAA also has a list of books there too. And the public library may also have different sections where you can have books to help educate children. I think also keeping in mind where create opportunities for children to experience mastery, independence, and realize that they can do it, right? If you notice that you're doing everything for your child, it comes with really kind intentions, right? Want to be helpful, and that may sometimes inadvertently send a message that they can't do it. So creating opportunities that they can do things. Maybe you help them practice ordering in the restaurant, right? But maybe role play with them, right? Give them a script, as we were talking about for kids who are, may present with symptoms on autism spectrum disorder. Maybe giving them scripts of like, they may also have social anxiety disorder, but they also may not know what to say in a situation. So role play with them, give them a script, and then give them opportunities to practice ordering for themselves, paying at the grocery store for your family, doing these things independently, trying to do things at home independently. That can also build a sense of mastery, and then realize, oh, wait a second, I can do it. It's not as hard as I expected it to be.
You touched on this earlier, but I think it's worth reinforcing as well. It sounds like you endorse the idea of involving a child in the treatment options as much as possible. In other words, they should be part of that conversation. Am I understanding you correctly?
Cognitive behavioral therapy with exposure and response prevention is very collaborative. The child's the expert on themselves, caregivers have a tremendous amount of expertise, and then the clinician is as well, and you need to partner together, right? But in CBT with ERP, you never force a child to do anything. They will not have trust, and they will not be willing to take those next steps, most likely. You need to have collaborate with them, be like, what would you be willing to do, right? Is this next step? And to help them stretch themselves. They won't know like what's on that hierarchy. They co-create that bravery ladder, that fear and avoidance hierarchy, the things they fear the least, the things they fear the most, and to gradually start working on things. And then as a caregiver, that you can then be the cheerleader, right? Who really cheers them on and praising their effort, not necessarily the outcome. Because we can't control the outcome, but at least if they're trying, that's something you want to reinforce.
Question specifically about the co-occurrence of anxiety and schizophrenia and or other psychotic disorders.
In terms of like the prevalence or what that might look like?
What treatment might look like for the co-occurrence of those two?
And it will depend on the stage at which, of the symptoms of psychosis or schizophrenia. So I think if those are right now primary, then you want to focus on those and having them managed first before you're doing the exposure and response prevention, because the exposure therapy is inherently stressful and you wouldn't want to exacerbate those symptoms or destabilize someone. So you would want to make sure that those are being managed first.
We sometimes hear about school avoidance. What is that term getting at, and what should we know relative to this conversation we're having?
So school avoidance isn't a specific diagnosis. It's kind of a manifestation of a whole range of different concerns. And one of the things, school usually houses everything and anything that a child could fear, right? And then it may make it difficult for them to go to school. It is very prevalent right now. So if a child has separation anxiety disorder, they may have trouble going to school. If a child has social anxiety disorder, they may have trouble going to school. So worried about participation. As I mentioned with the emetophobia, they may be worried about someone getting sick there, so they won't go to school, right? They're all range, or being trapped in the classroom or having a panic attack in school. So there may be all different reasons of what's contributing to their difficulty going to school. But it may look the same because in terms of absences and tardies.
Do you have any thoughts on accommodations and where they might fit into this discussions for kids in the class, dealing with those specific challenges that we've talked about today around fear and anxiety?
So partnering with schools and seeing if, we want to make sure that we're supporting the treatment and not accommodating the dandelions, right? And in that moment there too. So if the child is gradually working on their fears, is the school open to the child, like starting with one period per day and then gradually adding on time? And is the school open to maybe if the child's working really hard in treatment to lightening the like the homework load so that they can really focus on the treatment and not fall further behind. Because sometimes when kids feel like they're just drowning in work, it makes it harder to get there and still be responsible for, major tests and assignments, but that not for these additional papers where they may not necessarily need to complete them while they're working on this. Some schools may say like, oh, should we not call on a child if they have social anxiety disorder? And I would say like, it would not be in perpetuity if you're going to have a short-term accommodation. Maybe if you know that the child is in treatment and working on things and they're going to gradually work their way up to volunteering and participating, maybe it's short-term that you will not cold call on the child, but then over time that will get adjusted once they work their way up to treatment.
I want to ask you about a couple of societal issues that I imagine can factor into this. The first and obvious one is the pandemic. You were active, I assume, during the pandemic in treating kids and teens. In what ways has that exacerbated challenges for children and adolescents when it comes to navigating fear and anxiety?
Oh, the lockdown was necessary for physical health. And unfortunately, it was anxiety and avoidance's best friend in a way that it really reinforced avoidance. So if someone has separation anxiety disorder and they're home all the time with a caregiver, there was no practice in separating or interacting with peers in their classroom, right? Or going back to class, whatever their fear was. So that all strengthened avoidance and reinforced the anxiety. So when kids often had to go back to school and they lifted that lockdown, they often saw an exacerbation of their anxiety when they tried to return because they were out of practice. They hadn't done that. And it was for safety. It was necessary and totally got that rationale. And there were unfortunate consequences of that, as well as being removed from their peers, particularly adolescents, that could negatively impact their mood and exacerbate their mental health concerns. And so there are increases in rates, particularly in anxiety disorders and depressive disorders in youth during the pandemic across the world when they mentioned it for youth. And but the number of mental health clinicians did not increase commensurately.
The other specific question I had around what's happening in the world today is all the images of violence and war that are all over TV and as part of our conversations around the dinner table too often and so forth. How can parents and adults help kids and teens process that violence and those war images?
You want to think about to what is your child being exposed. So if you're someone who wants to be informed, you want to make sure like is the news running in the background in your household all day? Think about to what is your child exposed. So for children, particularly younger children, you don't necessarily shield them from everything in your household because they may hear things outside of your home. And also if they don't have all the information, they have quite the imagination and can think of some very scary things. And so you want to make sure you give them just enough. So I would start by asking them, what they do know already and what questions they have, and then sharing just enough to inform them with the ultimate punchline and message that you, as the adult, will do everything you can to try to keep them safe, or whatever, if they're having those worries. And, obviously, everything that you can that is within your control if they have worries about things spilling over into their community, if it's not there yet. But just giving them just enough and making sure that there isn't this running background of news exposure for them and the images, which can be particularly salient for them.
Over the past hour, and we are wrapping up this hour pretty quickly, time has just flown by. You've mentioned a number of resources, and I was going to ask you if you can sort of summarize for us again some of your favorite resources, whether they're webinars, or I'm sorry, not webinars, websites, books, videos. Where would you like to point people for additional information regarding kids and teens and phobias and fears?
So ADAA is a great one. So adaa.org, the Anxiety Depression Association of America. As mentioned, they've got lists of books, they've got webinars, they've got lists of providers, all sorts of, they've got descriptions of what each anxiety disorder is and their prevalence in youth. So that can help give some information and also perhaps point you in a direction for whatever it is that you're looking. There are, other organizations, particularly for other specific mental illnesses, like for someone who has ADHD, there's CHAD, there's a CHADD. So like there are different organizations for different mental illnesses, but I think if you're focusing on anxiety, I might point you to the direction of adaa.org. And then a pediatrician is also a great first line of communication, as they may know some of your local resources there. Sometimes people like going to
Excellent.
the Child Mind Institute. There's also some free resources there as well.
Jackie, one of the things we like to do with this webinar series is provide as much hope as we can to those in our audience around these particular challenges. And I know that there are parents who are watching who find a lot of this very daunting in terms of what their role is and how to deal with in the best way with their children and their challenges. Speak, if you would, to some of the hope that you have seen that comes through therapy and the loving involvement of families in their children's challenges and so forth. What should we know?
Oh, sure. I did not minimize. And then seeing your child in such distress has got to pull at every heartstring in your body and it takes over the whole family. It does not just affect your child. It takes over the whole family. It's all consuming. And the treatment goes against all of your instincts. And know that the treatment can help. I only say what I mean, and I show up to work every day excited to work with families as I get to see kids take charge of their lives again. It's really exciting to see them feel empowered and get back to doing what's important to them. And the treatment outcomes are measurable. If they haven't been going to school and all of a sudden they're going to school each class period 5 days a week, you can measure like that's a lot of change that has happened. Or they had difficulty separating from you and they just did their first sleepover, things to celebrate. So these things can happen. That being said, it's not an easy road or a smooth road, and know that treatment is not a linear line. It is a bumpy path. You will hit bumps. That's how it goes. And just remember, you are not back at square one. You're not back at the beginning, because all the tools that your child has been learning, they can't unlearn. They have been changing their brain in a really powerful and exciting way. And with extra practice, they can continue moving forward. So know that there will be bumps and know that treatment can be helpful.
Great place to leave things. Wow, Jackie, we've covered a lot of ground over the past hour, and you've done a fabulous job of explaining the importance of staying on top of these issues. And we very much appreciate all your time.
Oh, thank you so much for having me and facilitating everything.
Dr. Jacqueline Sperling, to those of you watching, thank you for your interest in our educational webinar series. We hope you'll come back for future sessions, and we wish you a wonderful day.